So dear students, today we are going to discuss some classifications that are very commonly asked in your exam. So before exams, we should be revising these classifications at a stretch and at a go. So let us talk about this classification system. So let us talk from GIT. So when we talk about GIT, the first system that we will be taking is liver. And when we talk about liver, there are 2-3 things that we need to understand. We have Okuda classification. Okuda classification, that is the classification for grading of liver. So it is a classification for grading of liver cancer, so HCC. When we talk about the Okuda, remember what are the parameters? We have bilirubin in this. So bilirubin, we have albumin, then what else do you have? Albumin, then we have tumor size, and then we also include ascites in this. So merely presence or absence of ascites, bilirubin levels are there. So we define this Okuda. Not much on this I shall be discussing here. It is just last minute revision. So we'll be just taking the name. So one is Okuda. Then we have what classification? We have other classifications like QP and CLIP. What is CLIP? What is CLIP classification? That is cancer of liver, Italian program. So cancer of liver Italian program, and what are the things that we include? So it also includes certain important things. What are they? Child's Turcot Puck score. So CTP score. So Child's Turcot Puck score. Point number 1. Second is it includes portal vein thrombosis. So portal vein thrombosis is there or no? Thrombosis. Then it also includes one very important thing. What is that? Presence of alpha fetoprotein levels. So what are the alpha fetoprotein levels? Then what else is including? The fourth and the last is the tumor morphology. So the tumor morphology. There are 2 more classifications that we need to understand here. The third is we have QP. What is QP, students? Chinese University Prognostic Index. Chinese University Prognostic Index. When we talk about Chinese University Prognostic Index, it includes the TNM, it includes the bilirubin, it includes ascites, it includes a lot of things, but one very important thing is that alkaline phosphatase is included. Presence or absence of encephalopathy is also included. These are the important classifications related to liver. There is again one more thing, Barcelona Cancer Liver Classification or BCLC. So this is a Barcelona's classification. When we talk about Barcelona's classification, this is rejected by the American Association. Most of them don't follow. But yes, if you're reading Love and Bailey, you will always find it. So it's a classification. Along with that, there's a management protocol also for the hepatocellular cancer. Then we go to the gallbladder system. So when we talk about the gallbladder and bile duct, we don't have a lot of, you can say, classifications, except we have a very important, that Alonso and Todani classification. When we talk about Alonso and Todani's classification, what is this classification for? This is a simple classification for choledochal cyst. I have made a lot of videos on this choledochal cyst concept, and according to this, there are 5 types of choledochal cyst. Type 1 is, I'll just brush up. Type 1 is cystic, and cystic dilatation of biliary tree or CBD, and then we have 1A, 1B, 1C. Remember, type 2 is a saccular dilatation of the supraduodenal CBD. So saccular dilatation of the supraduodenal CBD, this is again one. Then type 3 is the intraduodenal, that is also known as choledococele. So that is choledococele. And then we have type 4, which is multiple extrahepatic plus minus. So extrahepatic plus minus intrahepatic. Remember, if both are present, it is a 4A. If one is only extrahepatic is present, it is 4B. Then 5 is, this is also known as Caroli's disease. So when we talk about Caroli's disease, you should know that Caroli's disease is multiple or solitary intrahepatic cyst. So these two things you need to remember, type 4 and difference between type 4 and type 5. Then there is the second classification that you need to understand and know about the biliary system. That is what is very important, is the Strasberg and Bismuth classification. So the Strasberg Bismuth classification. When you talk about Strasberg Bismuth classification, this is a classification for what? Biliary injury. So it's a classification for biliary injury, and one more thing, that is the strictures, and they are very commonly asked. Type A is defined as a cystic stump leak. So cystic stump leak or minor duct injury, minor or unknown duct injury, that is what is, so minor duct injury. Then type B and type C deal with segmental duct injury. So segmental ducts, like right posterolateral duct without any bile leak. So segmental, if you ligate the duct and there is no bile leak, but you have injured the duct. So segmental duct injury without leak, that is what is type B. What is type C? Segmental duct injury with leak, that is type C. Type D is a lateral wall, it's a lateral wall bile duct injury. So major injuries are on the bile duct, and major bile duct injuries are classified as type D. Type E is nothing but strictures, and when we talk about strictures, we should be knowing E1, E2, E3, E4, E5. E1 is strictures more than 2 cm from hilum. E2 is defined as stricture less than 2 cm from hilum. Then E3 is defined as stricture at the level of hilum. Then E4 is defined as stricture involving the right plus minus left. So it could be, you can say that segmental duct strictures. So segmental duct strictures, but the hilum is spared. So with hilar sparing, spared, this is what is very important. And then what is E5, students? It is E5 involving the right plus left duct. So right plus left duct plus hilum is involved. This is what is very important. Then I would just write the name of one of a classification which we actually know as Bismuth-Colruyt classification. So just the name of this Bismuth-Colruyt classification. This is for hilar or perihilar cholangioCA. So I would say that cholangioCA. This is what is again very simple thing. Now moving out to pancreas. So when we talk about pancreas, there are a lot of classifications that we have. One of them is Atlanta's classification. When we talk about Atlanta's classification, it is nothing but the classification for acute pancreatitis. So acute pancreatitis and its complication. This is what is the Atlanta's classification. You know, according to Atlanta's classification, we have before 4 weeks, we divide it into 2 groups, before 4 weeks and after 4 weeks. So before 4 weeks, when we talk about, we have acute pancreatic fluid collection, APFC, when there is only collection of pancreatic fluid. And if there is necrotic peripancreatic tissue also, we say APNC. What is APNC? Acute pancreatic necrotic collection. That is what. The same thing after 4 weeks will form a well-defined granulation tissue wall, and that becomes pseudocyst. So pseudocyst is a complication after 4 weeks. Similarly, APNC after 4 weeks will convert itself into VON. What is VON, students? Walled of necrosis, or walled of necrosum, anything you can say. Then what are the other classifications that we have? The second classification that we talk about pancreatitis is a D. Edigios classification. D. Edigios classification is a classification for pseudocyst. I'm not going into the great depth. We have 3 gradings of D. Edigios. So pseudocyst associated with acute pancreatitis, pseudocyst associated with acute on chronic pancreatitis, acute on chronic pancreatitis, and pseudocyst associated with chronic pancreatitis. The only thing that you need to understand, or the crux, is that in acute pancreatitis the duct is not connected with the pseudocyst. In acute on chronic there's a 50-50 chance, so there can be a stenting also. In type 3, yes, it is always connected, and therefore we go for the stenting. Apart from this, there are two other classifications. We have Cambridge classification. So it's a Cambridge classification is a classification for chronic pancreatitis, and it is ERCP based classification. It is ERCP based classification. Then fourth is we have a Rosemont classification. We have a Rosemont classification. This is again for chronic pancreatitis, and this is EUS, ultrasonic under, you can say endoscopic ultrasound classification. So we get to see certain parenchymal features, certain duct related features. So that is how we classify them. Then we also have a classification known as Marsali-Rome classification. Marsali-Rome classification is a classification for chronic pancreatitis, which redefines pancreatitis into lot of conditions like chronic calcific pancreatitis, where there is calcium deposition into the duct. Then there is chronic obstructive pancreatitis. Now this is due to the ductal strictures resulting in obstruction. And then it is chronic autoimmune pancreatitis. So this is Marsali and Rome classification. Students, when we are talking about the strictures, there is one more classification for SOD. What is SOD, students? It's a very simple condition, that is sphincter of Oddi dysfunction. So sphincter of Oddi dysfunction, and when we talk about sphincter of Oddi dysfunction, one very important thing that we all need to understand is that sphincter of Oddi, we have Milwaukee's classification. When we talk about Milwaukee's classification, we need to understand that SOD is of two types. It could be a stricture, or you can say it could be the SOD due to the problem with the bile duct, and it could be a SOD due to problem with the pancreatic duct. So it could be a biliary SOD, versus it could be a pancreatic SOD. So pancreatic SOD versus biliary SOD. You should understand that if you have obstructive jaundice like features, so what do you get to see here? We have further grading into three types: dilated CBD plus minus obstructive jaundice. This is what you get to see here. Here you get to see dilated MPD, main pancreatic duct, plus minus acute pancreatitis like features, and plus minus elevation of amylase and lipase. Here also, when you talk about the features, you get to see the features of what colic? Biliary colic. This is what is very important. Now we have completed liver, gallbladder, pancreas. Now we go to esophagus. So when we talk about esophagus, what are the things that we need to understand? We have certain classifications, and one of the classification is the classification of esophageal atresia. So esophageal atresia or tracheoesophageal fistula. So the classification for them is very simple. We have A, this is pure atresia, We have type B, that is atresia plus proximal tracheoesophageal fistula. Type C, it is atresia plus distal TEF. Type D, it is atresia plus proximal plus distal TEF. This is again very complicated variety which is rarely seen. And type E is side to side tracheoesophageal fistula with no atresia. This is what is very simple. Order of incidence, if we talk about type C greater than type A, greater than type E, greater than type B, and D is the rarest type. So this is one classification that we need to know about esophageal atresia. Then when we go to the next classification, we have a classification for PEH. So when we talk about the classification of PEH, you must be thinking what is PEH? PEH is nothing but paraesophageal hernia. So we have type 1, which is sliding hernia. I am not going to repeat it. In sliding hernia, the G junction migrates up. So G junction migrates up. In type 2, which is known as rolling hernia. So type 1 is the most common, type 2 is the least common. Rolling hernia, what is that? The G junction is static. The G junction is static. The fundus plus minus other parts, that is generally the body, they migrate up. That is what is. Then what is type 3? Type 3 is a combination of type 1 and type 2. And then what is type 4? It is herniation of any structure. So herniation of any structure other than your classically your stomach. So this is what is type 4. So type 1, type 2, type 3, type 4. This is very, very, very important thing that we need to understand. Then after that, what are the other classifications that we need to understand, or other important tables that we need to understand? After this, when we move to GERD, you know that in GERD, there is one very important thing that we need to understand is the concept of gastroesophageal junction and gastric valve. So there is a grading which is known as Hill's classification. So Hill's classification is for grading of gastroesophageal valve, that is, or you can say gastric flap also. Gastric flap, those who don't know, it is simply like this. So when we talk about this angle of Hess, so normally this is like this is type 1. So acute angle of Hess, this is what is known as, grade 1. Then what is grade 2, students? Grade 2 is type 2. It is acute angle of Hess, with a gap. Type 3, it is non-acute angle. So you can say it's a type where the loss of acute angle. So there is a loss of acute angle with wide gap. This is what is type 3. And then we have type 4, where you get to see sliding hernia. So sliding hernia, when the G junction itself migrates out. So Hill's classification is, if the name is asked, then you should be telling. In my classes, I have discussed this in depth and detail. So today I am just giving you the names. Apart from this, what are the other classification? One more classification that we talk about is Chicago's classification. Chicago's classification is for esophageal motility disorder. And particularly when we talk about esophageal motility disorder, we have one more main important thing, that is achalasia. So it is specially for achalasia, type 1, type 2, type 3. There are 3 grades of this: type 1, type 2, type 3. What is type 1? This is aperistalsis, and along with that there is loss of peristalsis. Plus, what is the basic concept of achalasia? The concept of achalasia is that the loss of neuron starts at the level of what, students? At the level of G junction. So there is hypertensive LES. Why? Because unopposed cholinergic action. So aperistalsis plus HLES, hypertensive lower esophageal sphincter. This is basically type 1, and this is a classic type of achalasia that we get to see. Now as the achalasia progresses, there will be increased loss, and thus the acetylcholine will be acting on complete esophagus, and this will convert into something like pressurized esophagus. So this is aperistalsis, along with that HLES, and along with that panesophageal increased pressure. So panesophageal increased pressure. This is what is a type 2. Then what is a type 3? This is what is known as vigorous. So vigorous achalasia, vigorous achalasia, or you can say spastic achalasia. So what is that? This is achalasia with powerful, you can say spasmodic or spastic simultaneous mirrored contraction. So high amplitude, normally we get to see low amplitude contraction, here you get simultaneous mirrored. So lot on this in the class, but here just I am revising the, you can say, classification. Simultaneous mirrored contraction. What are the other classifications, the names of those classifications that you need to know in the chapter of esophagus? So when we talk about esophageal perforation, there are two named classification associated with it. One is a Pittsburgh classification, and there is one more which is known as Cameroon's criteria. What is Cameroon's criteria? Cameroon's criteria is for the conservative management. So it is for the conservative management in case of esophageal rupture. So whenever you have an esophageal rupture which is contained to the thorax, there is no peritonitis, mild symptoms, no sepsis, in that case you can, and vitals are stable, in that case you can also go for conservative management. Then when we go to the chapter of stomach, you also have certain classifications here, and the most important here is Sydney's classification. When we talk about Sydney's classification, what are the important things that we need to understand in this Sydney's classification? Very important. It is nothing but a classification for gastritis, and you know we have type A gastritis, type B gastritis. Type A gastritis, quickly remember the 6 A's. What are the 6 A's? It is autoimmune. The next is, there is you can say, because of this autoimmune nature, there are a lot of things that will happen. You will have auto antibodies against the parietal cells. So because of this, there is anemia. So pernicious anemia is there, pernicious anemia is also there, and megaloblastic anemia is also there. Then there is high risk of adeno-CA. Then there is antral G cell, antral sparing also, and then there is antral G cell hyperplasia. So antral G cell hyperplasia. Then one more thing is that there is atrophy of parietal cells. So atrophy of parietal cells, and since there is atrophy of parietal cells, what you will get to see? Achlorhydria. So there are a lot of things that we need to understand. Then according to this classification, we have type B gastritis also, we have reflux gastritis also, we have erosive gastritis also, we have stress gastritis also, we have granulomatous gastritis, associated with the infections, so like tuberculosis, etc. Then we have steroid induced, we have phlegmonous gastritis also. So there are a lot of things that we need to understand here. Then moving to the chapter of stomach only, we have other classifications for CA stomach. When we talk about CA stomach, we have a classification which is known as Lawrence classification, and according to Lawrence classification, we have two broad type. We have a diffuse type of CA stomach, and we have intestinal type of CA stomach. So intestinal type and diffuse type. You know, diffuse type is more common, and it is also associated with young generation, obese, blood group A, and lot of things, like it is associated with direct spread, lymphatic spread, as well as hematogenous spread. It is the one which is associated with poorer prognosis, and you must have heard of Linitis plastica also, which is also seen here. Then we have Japanese classification. This is for early CA stomach, that is involving mucosa and submucosa. Then you also have a Borman's classification. Leave all the things. Remember, Borman's type 4 is nothing but Linitis plastica. These are certain things. Then we have a classification for gastric polyps also. So what is the classification of gastric polyps? Let us try to understand. When we talk about gastric polyps, they are classified into two types: neoplastic and non-neoplastic. So we have neoplastic and we have non-neoplastic. So these are two important things that we need to understand, that in neoplastic we have certain polyps like adenomatous. So adenomatous polyps. Then we have the fundic polyp. Then we have hyperplastic polyp. Do you know the most common gastric polyp overall? This is the most common type. Then we have inflammatory polyp. These are the polyps that we have. Then let us talk about, there is a small classification on the gastric carcinoids also. So classification of gastric carcinoids. So when we talk about classification of gastric carcinoids, you need to understand that there are 4 types. Type 1, this is associated with atrophic gastritis. So type 1 is associated with atrophic gastritis. Therefore, achlorhydria is a classical feature here. Achlorhydria. Type 2 is what is type 2? This is again associated with, you can say, hyperchlorhydria with hypergastremia. So this is associated with Men syndrome. Or you can say Zollinger-Ellison syndrome. Do you know type 1 they are benign, type 2 they are mostly benign, less than 10% are malignant, otherwise they are benign. Then type 3 and type 4 they are both are sporadic type. So type 3 and type 4 they are sporadic. But what is the class? Sporadic but malignant. What is the classical difference between type 3? Type 3 is generally less than 5 centimeter and type 4 are the varieties which are more than 5 centimeter. This is again very simple. Let us move to the intestine and stomach. In collaboration, we have certain tumors, that is gastric lymphoma. So we have gastric lymphoma. There are certain classifications for that also. The first is the Dawson's criteria. What is the concept of Dawson's criteria? Dawson's criteria is a clinical criteria for diagnosis of gastric lymphoma. Do you know what do you mean by this Dawson's criteria? There are 5 features. Clinical evidence of lymph nodes should not be there. No mediastinal lymphadenopathy seen on CT scan. The blood parameters should be normal. The marrow should be normal, and the disease should be isolated to the stomach itself or intestine itself. That is what is the criteria for gastric lymphoma. Otherwise, it would be a lymphoma with GI metastasis. The second that we have is a Mashoff's classification. So what is a Mashoff's classification? It is too long to discuss here, but you must have heard of Ann Arbor system. Single site lymphadenopathy, bilateral lymphadenopathy above the diaphragm and below the diaphragm. That is what is modified Ann Arbor system. Modified Ann Arbor system. This is what is. Then let us go to the GIST. When we talk about GIST, what is that? Gastrointestinal stromal tumor. So you know that there are 3 important features: tumor size, mitotic count. Tumor size, mitotic count and tumor site. Let me tell you something about GIST, that for the GIST we have a classification which is known as a Fletcher's classification. So Fletcher's classification or Fletcher's grading, this is how we see as very low risk tumors, very low risk. They are the one with size less than, so size and then mitotic count. Size and mitotic count is very important. So size less than 2 centimeter and 0 mitotic count, no mitotic count detected. Then low risk is 2 to 5 centimeter tumors. So 2 to 5 centimeters without any mitotic count. Intermediate risk, there are 2 criteria: more than 5 up to 10 or less than 5 with less than 10 per 50, or you can say with less than 10 per 50 high power field mitotic count. Yeah, this is what. Then we have high risk. What are high risk students? They are more than 10 centimeter or more than 5 centimeter with more than 10 per 50 mitotic count on high power field. These are what are very important. So this is Fletcher's grading. Then when we go to the colon, chapter of colon, so we have certain more grading systems in intestinal system. Let me tell you 2 more things about atrachia. So when we talk about atrachias, we have a grading for or classification for duodenal atrachia. What is the classification for duodenal atrachia? What is that? Let us simply see. Duodenal atrachia. There are 3 grades: type 1, presence of webs only. So this is an atresia where you have only the presence of the webs, and this is the variety which is actually or truly known as wind sock defect. So wind sock defect, this is what is very 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 simple. Type 2, type 2 is atresia without separation. So it's a atresia without separation. And then we have type 3. Type 3, what is that? Atresia with suppression. So atresia with suppression. So atresia with separation of the mesentery. Atresia with separation of mesentery. This is again very 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 simple system of grading. Then we have again a classification which is by the name of there's a classification for jejunal-ileal atresia. So what is that classification for jejunal-ileal atresia? Jejunal-ileal atresia. That's a Quran classification. Quran classification. Gosfred and Quran. So it's a Quran Gosfred classification. No need to remember the names. They are quite tricky, and I have also stopped teaching them over the time. What is that? Type 1 is the presence of webs. Type 2 is complete atresia without separation. You must be knowing this. So complete atresia without any separation. Type 3 is again of two types. You must be knowing that. Type 3 is further divided into 3A, where there is a V-shaped defect of mesentery, V-shaped gap at the level of mesentery. This is one. And then type 3B is apple peel defect. Apple peel, I have recently discussed this on social media also about this apple peel question, and many a times in class also. Apple peel defect. And then type 4 is multiple atresias. So apprecias, or you can say string of beads appearance. So string of beads appearance. These are certain important things that we need to understand. Then when we talk about other classifications of intestinal, you can say intestine, small intestine, we have one more classification, that's a standard classification. Standard classification. What is this standard classification? This is for mesenteric ischemia. So one more is mesenteric ischemia. Now according to this, we have two types of mesenteric ischemia. We have acute mesenteric ischemia, we have chronic mesenteric ischemia. So we have acute, we have chronic. So we have acute as well as we have chronic. Now acute is further divided into lot of types like acute embolic. So acute embolic or acute embolic, or before that we have acute arterial, we have acute venous, and then we have something where we get to see vasospasm. So that is known as NOMI, non-occlusive mesenteric ischemia. So it's just like a Prince metal angina. So non-occlusive mesenteric ischemia. Then arterial is further divided into two. One is embolic and one is thrombotic. So more on this later in the chapters. Right now we are just cruising through this classification. Then let us go to the colon, and in colon we have a very important classification which is known as Hegget's classification. Now when we talk about Hegget's classification, it is nothing but a classification of colonic polyp, pedunculated type, basically showing us the tumor. So depending upon where the tumor is, it can be Hegget's 0. So tumor at the level of the apex. Tumor at the level of the head. So 1 is for the head, 2 is for the neck, 2 is for the level of neck, 3 is for the level of stalk. So if the tumor is at the level of stalk, then it is 3, and then this is mucosa, this is submucosa. Tumor at the level of root, this is what is type 4. So type 4, it is at the level of root. This is what is Hegget's classification. Remember all the sessile polyps. So this was for the pedunculated, so mucosa and submucosa. All the sessile polyps, they automatically qualify for Hegget's 4. Now you must be knowing about one more classification which is known as Kudos classification, and Kikuchi's classification. So Kikuchi's classification or Kudos classification, what is this classification all about? Remember, the sessile polyps are further divided. So this is mucosa and this is submucosa. Now if we further subdivide the submucosal thickness, we will subdivide it into the third quarter. So if we divide them into the threes, so remember, if the tumor has gone up to the level of upper 1/3, this is known as SM1. What do you mean by SM1? SM1 means up to the upper 1/3, middle 1/3, submucosa and lower 1/3 submucosa. So if the tumor goes and reaches up to middle 1/3, that is what is known as SM2, and if it is managing to reach up to the lower 1/3, it is known as SM3. Remember, what is the logic here? I will quickly discuss with you. Remember, SM1, we go for snare polypectomy. This is what is very important. If it is SM2, we wait. This is an equivocal scenario where the decision is taken by the consultant, but SM3 we always treat like adeno-CA. So it is treated like adeno-CA. These points are very important, and this is an equivocal scenario where the decision is taken by the doctor. So by consultant, he sees whether we can go for snare versus the treatment like segmental resections that we do, right hemicolectomy, left hemicolectomy. There are a lot of important things like family history, the age of the patient, whether any high risk feature is there. So this is how we actually see. Now when we talk about Heggett's, how do we interpret Heggett's? Always remember, in Heggett's classification, if it is Heggett 0, Heggett's 1, it is Heggett's 2, Heggett's 3, you always go for snare polypectomy. This is what is. If it is Heggett's 4, then it is treated like adeno-CA. So this is what is very important, and with this I finish the session for the most important classifications and grading systems for the GIT. I hope, students, it will help you a lot in your revisions. However, there are other classifications and systems, but this is a huge unit. It is not possible to cover all the topics in one go. Thank you for watching my lecture. Do share it with your friends and do subscribe to my channel, and एक like तो बनता ही है.